Okay, hi everybody. Welcome to the third in our Craniosynostosis series, specifically our journal club session. We have a few different announcements for you that we'll try to get up on the screen shortly. There we go. So first, tune into the Neurosurgery Journey live every Thursday at 7 Eastern. We also wanted to share that our Women in Neurosurgery event is coming up on February 25th. Sorry, things are a little bit out of order here. In addition to that, the next thing on our list is we're going to be talking about the clinical students guide, I think on Thursday for our next live. And we are also doing a service fundraiser currently for brain and spine injury. So there's more information there on how you can donate. Our goal is to get to $15,000, and we definitely need your help to do that. Okay, so I think that's about it. This one.
That's all the announcements?
I think so.
All right, so get everyone introduced and warmed up before we dive into the meat and potatoes then?
Yep. So we have Dr. Meltzer joining us this evening. How are you doing tonight?
Doing great. Thanks for the invitation.
Yeah, of course. Just give me 1 second here.
I think there's another student presenter joining. I'm going to be pinch hitting one of the articles. I guess presenting journal club is not people's preferred Valentine's Day activity, but I guess there's 3 articles we're going through tonight. So I'll present one, Nikki's going to present one, and then there's another student maybe having some link access issues, but we'll get through everything and have a good time doing it.
All right. So just to introduce Dr. Meltzer before we get started, Dr. Meltzer is the chief of West Virginia University Medicine Children's Pediatric Neurosurgery. He received his MD from Northwestern University here in Chicago, where I am currently, and completed his residency at the University of California, San Diego Medical Center. Dr. Meltzer was recruited to act as a thought leader for developing pediatric neurosurgery at West Virginia University. His specialties lie in the treatment of craniofacial disorders, including the development of novel, minimally invasive endoscopic procedures, as well as innovative cranial vault expansion techniques. Dr. Meltzer was always interested in medicine, even as a child, primarily because of the opportunity to help people and to make a difference in people's lives and society. During his medical training, he was drawn to neurosurgery, and then came the opportunity to work in pediatric neurosurgery. He grew up in Chicago and practiced for over 20 years in San Diego before being lured to West Virginia University Medicine by his colleague and mentor, Dr. Mark Lee. So with that, I think I will go ahead with the first presentation here, and then we'll have a few minutes for discussion after that. And then we'll move on to our next presentation. And we would, Dr. Meltzer, before we get started, if there's anything that any comments that you wanted to make or further introduction, we would love to hear it, but otherwise we can get started and kind of discuss as we go. It's up to you.
I think we should jump right in, but thank you for your kind words.
All right, give me 1 second to get this on screen.
And obviously, anybody in the audience, if you have questions, comments, anything you want to bring up, just go ahead and send it right in the chat. There's all of us here kind of watching, monitoring. We'll throw your questions up on the screen so everyone else out there can see them. And, we'll have a good time doing it. So with that, I'll be here monitoring chat until it's my turn.
All right, does that look okay on screen?
Yeah, it looks good on my end.
Okay. All right. So just to get started, we're going to start with I should say the first of these 2 articles were chosen from the Congress of Neurological Surgeons list of landmark papers in neurosurgery. So they are a little bit older, but they are nevertheless very important papers in defining craniosynostosis management. The first one is Sagittal Craniosynostosis Outcome Assessment for 2 Methods and Timing of Intervention. And it was published in 1999. So bear with me. I believe this was a photocopy of the article because I had trouble finding a digital copy. First, a little bit about craniosynostosis. Craniosynostosis is a birth defect where the bones in a baby's skull fuse too early. So the soft fontanelles in a baby's head or the lack of closed sutures allows the baby's head and skull, or the skull, to grow along with the brain. And when craniosynostosis occurs, you can have various sutures. The sutures that fuse too early define the type of craniosynostosis that prevent the brain from growing normally. And if it goes untreated, that can lead to buildup of pressure in the brain that can lead to various problems, including blindness, seizures, or brain damage. And in addition to that, what probably most parents end up coming in and seeking treatment for is the fact that there's distortion of the skull as this problem goes on that causes essentially abnormal skull shape, which is usually what parents end up coming in for. So the research question for this paper was which type of surgical procedure has the best outcome for craniosynostosis, specifically sagittal craniosynostosis, extended strip craniectomy or subtotal calvarectomy. This was a retrospective quantitative analysis, and it included children that had non-syndromic sagittal synostosis, had an operation before the age of 13 months, and had 3D CT scans completed before surgical treatment and approximately 1 year after surgical treatment. Some of them also had perioperative CTs. And as I said, this was specifically for sagittal synostosis. So this first figure kind of demonstrates the two different types of procedures that were used. The one on the left is the extended strip craniectomy. So they essentially remove an H-shaped strip of bone from the skull without really affecting any of the other bones in the skull. So no osteotomies are performed on the frontal bone, the temporal bone, or the occipital bone. By contrast, the subtotal calvarectomy and cranial vault remodeling involves multiple radial osteotomies on the frontal bones, as well as on the occipital bone. And so they essentially remove the bones and then reshape them and do some remodeling of the skull. So it's a bit more extensive than the extended strip craniectomy. So for this study, they had, I believe they initially had about 60-something potential subjects. They got whittled down to 40 based on their inclusion criteria, and they had 28 that underwent the extended strip craniectomy and 12 that underwent the subtotal calvarectomy. There was definitely a skew toward male babies in this study. They didn't specifically comment on that, but the ages for the groups were about the same. And to assess the outcome from the various procedures, they used cranial index, which is the ratio of the maximum width to maximum length. So width divided by length times 100 is how you get the cranial index. This can be measured with skull radiographs, direct measurements of the skull, or CT scan data, which is what they were using in this case. And that's really, at least up until this point, maybe there are now other ways that they assess this, but at the time that was kind of the best way to really assess the outcome of these procedures. So they were looking at both the different types of procedures, the extended strip craniectomy and the subtotal calvarectomy, and also the timing of the procedure, because they looked at babies that had this done prior to 4 months of age and after 4 months of age to see if the timing of the procedure played any role in the outcome. So as you can see here in this table, there was a greater average percent change in the cranial index following the subtotal calvarectomy as opposed to the extended strip craniectomy. So almost twice as much change when they looked at the preoperative relative to the postoperative cranial index. They did remark that, and I think it sounded from the paper that this is pretty typical, that there was a bit of a regression in between compared to the sort of immediate postoperative cranial index to a year later, that they kind of saw some regression in the cranial index that then went back to normal over the course of a year. So they have some photos here of the 4 days post-op for the extended strip craniectomy and the subtotal calvarectomy with those 3D CT scans that you can see. So what they looked like immediately afterwards, essentially. And then as they went on, they graphed this to look at the change. It's kind of hard to see with the different tones that they used for extended strip craniectomy versus subtotal calvarectomy, but the solid color is the subtotal, and then the other shade, the other color is the extended strip craniectomy. So you can see that most of those patients fell to the left of the graph, meaning that they didn't have as much of a change in the cranial index over time compared to the subtotal calvarectomy patients. And they also looked at, so on the left graph is extended strip craniectomy, on the right graph is subtotal calvarectomy. And the gray area, which again is hard to see because this is a photocopy, so I apologize for that. The gray area is what is considered normal range for cranial or cephalic index. And they found that a greater number of babies in the study after a year ended up in the gray area or the normal range on cranial index than did those that underwent the extended strip craniectomy. So each of those marks represents a participant in the study, and then the shape of the mark indicates whether that was their measurement pre-op, peri-op, or post-op. So again, this is some of those images. You can see what this looks like after a year of one versus the other, and that there's been a lot more, I apologize for the noise, continuous remodeling of the skull in that subtotal calvarectomy group relative to the extended strip craniectomy group. Then looking at the statistical comparisons of the effect of the surgical procedure on cranial index, the difference actually wasn't ultimately significant, but they did find, as you could see there, that there were better outcomes with the subtotal calvarectomy in terms of the pre-op versus post-op findings. And then this next table looks at the age of operation. So specifically in that extended strip craniectomy group, they compared when the procedure was done at or less than 4 months of age versus over 4 months of age, and found that there wasn't really any differences there, because I think traditional wisdom at the time kind of suggested that the earlier the better, and they didn't in this study at least find that to be true. So that's what we're looking at here. I apologize. So the main conclusion of all of this really is that even though the subtotal calvarectomy with the surgical remodeling is a more extensive operation, relatively speaking, if the goal of the surgery is to normalize the cranial index, then that operation is generally more effective than the extended strip craniectomy in doing so. And the age at surgery, at least for the population here that was between 1 and 13 months of age, did not affect the outcome for these particular operations. So I will leave it at that, and we can maybe have some discussion of that before we move on to the next one.
Yeah, I just went ahead and brought in everybody on the panel. We can kind of open it up for discussion. If Dr. Meltzer has comments or anything he wants to start with, now I've got a question or so I can sprinkle in as the conversation progresses.
So, Nikki, what did you think of this paper? Do you have any thoughts about it after you reviewed it and studied it? What do you think?
I mean, I'm not sure if it's more common for male babies to experience this, but I did think it was interesting that the groups were so skewed towards male babies. That was one of the first things I noticed was, is that to be expected in a study like this? Or is...
I always wonder about that kind of thing, especially in things that are 20, 30 years old.
Right.
You wonder about gender bias. I don't know so much in this particular study, but I will share with you one story from a pediatric neurosurgeon in another country that gave a talk about a surgery they were doing called endoscopic third ventriculostomy that has a very high rate of not working in certain populations. But he said, we do it a lot in girls because people don't really care how they turn out anyway. They don't have to do much more than cook and clean. So we don't really, it doesn't really matter that much. And that was you couldn't get away with that. You really couldn't get away with it then. Now forget it.
Yeah.
It's outrageous. But you always wonder, is there something going on, right? When people make these decisions, someone says, well, that's okay. We're not going to change this head shape. It doesn't matter that much anyway, versus someone else. And there are biases, right? There's biases. There's racial biases, gender biases. There's economic biases, right? These are like really important topics. There's a lot of literature about this now. If you look at more modern literature. So I think that always does have to go into your thought when you're looking at something critically. That might be the first thing that could come to your mind. But I would also let you know that it's also known that for whatever reason, and I think this is pretty much bias taken out. This disease seems to be more common in men than women.
Okay.
So reasons that are unclear, but it does seem, and it's well known, that it does seem to be more common in men than women. But I think it is worthwhile to look at that. And I think anything you look at these days, you've got to look at it through all the different bias lenses because we know they exist. So I think that's a very valid comment to make. Although I think in this case, it's been shown that for whatever reason, this disease happens to be more common and no one really knows why, but more common in men. So now, but I will tell you there is bias in this paper though. Maybe not in that, but there's other areas where there is bias in this paper. So what do you think of the names that they named these two procedures? Which procedure is actually the bigger, more invasive procedure?
I mean, the subtotal calvarectomy from the images appears to be more invasive.
When you hear the word subtotal, do you think that
doesn't sound less invasive or more invasive? It sounds less invasive.
Yeah.
And what's the other surgery called? And
Extended.
they call that surgery.
Yeah. The extended makes it sound like it's extended.
There's some messaging going on here that these authors have got some bias where, and I know who some of the authors are, and they're not known for promoting minimal invasive procedures or endoscopic procedures. So I think that, there is some messaging, maybe subconscious or conscious, the way they name these procedures. Yeah. They name the more invasive, aggressive procedures subtotal, and the less invasive, they call extended. So that's already, and then how about what kind of comparisons do they look at? Do they look at things like length of stay, blood loss, risk of transfusion? Was any of that included in there? Yeah. I mean, they probably had that data was available, right? Did they look at that data at all?
You would think, because it's a retrospective study, so you would think that all of that information would have been available, but they focused exclusively on the cranial index, which they even acknowledge that doesn't take into account a lot of other factors that go into a decision to do a procedure like this, like the cosmetic aspect of it, the sort of psychosocial aspects of having a big procedure like this are sort of not taken into account by a cranial index. That's really, it's a measure of length and width of the skull at the end of the day.
Mm-hmm. Although maybe the best we have right now, although I'm reviewing a paper that they talk about some other indices they're working on, but there is a criticism of this, but it's what we have. So I don't think that necessarily is a poor metric. But I think there's more metrics than that. When you compare a procedure to another, it's not just what one outcome measure is. There's a lot of data you can look at. And I think what you'll find if you look at papers critically, you'll see that very rarely do the authors have no kind of internal bias before they start. They typically have an idea of what they think is the best, and they'll tend to highlight that. They'll it's like an argument in a court of law. You're going to highlight the things that are going to be in your favor and not highlight the things that aren't when you're making your argument. So now the best papers tend to be even-handed, but I might suggest there was some data probably left out that might have made things a little more not so straightforward as to which is the quote unquote better procedure. But I think from a historical standpoint, this paper is important because it tells you that if you do like a strict craniectomy or a suturectomy alone, that probably is not enough. That's historically maybe 100 years ago when people were first trying to do any procedure, and you could die on the operating room table from blood loss with these procedures. A minimal procedure was the safest. But just doing that, removing one strip of bone, is probably not enough to get you a reasonable result in modern times. I think in that sense, this paper is very helpful in that it kind of puts to rest that you can't just remove probably a strip of bone. You've got to do more than that. And so they show a procedure where they do a lot more than that, and it seems to be a better outcome. So I think in that sense, that's why this paper, or some people consider this paper to be very important or a landmark paper, because it does kind of put that to rest as things evolve, as knowledge evolves over time. But if you look at that one slide you put up of the outcomes and which group had outcomes in that gray zone, I might argue that neither procedure looks very good to me.
Yeah, I had the same thought.
You should all be in the gray zone. I mean, the point is that, craniofacial surgery, people, back in the day, they would make jokes, weren't very nice jokes. And people would say, well, this is craniofacial surgery. You're taking people who are deformed and you're making them look ugly. I mean, it's not really, in other words, it's not really giving you want to take someone and make them look normal. You want to do a surgery that corrects the problem, that maybe makes it a little bit better. And when you show that graph of all these numbers that are outside, even the best, the so-called better surgery still has a lot of people that are outliers. So it means, to me, we have a lot of work to do. At least 20 years ago or plus, we still had a lot of work to do to get people with outcomes that we would consider acceptable outcomes, which would be in the normal range. That would be your ultimate outcome, not just to look improved, but you would want to be in a normal parameter. So I think that's another take-home message. And look at this paper historically is that we had a lot of work to do still, to get to where we need to be, get the outcomes where they need to be. You should all be in the gray zone, ideally.
Yeah, absolutely.
Or in the gray zone, but you should all be in that gray zone.
Yeah, and I wondered too, with the advancements in plastic surgery as well, how that's helped to contribute to better overall shaping the skull, to your point about, reaching normal as opposed to just fixing a deformity. Great.
It was a really nice job, by the way. Really nice job.
Going back to the original topic of discussion about gender bias, the question that had come up in my mind is, in your clinical practice or just kind of anecdotally over the course of your career, have you seen that parents make either different surgical decisions for their baby boys versus baby girls, or maybe if it's not whether to operate or not operate, but to allow their daughter or son to be enrolled in a trial that you think could be skewed towards a bias of, maybe we're okay with having our son enrolled in a trial if they want to collect data on him, but we're not going to have our little girl enrolled in a trial, or vice versa in terms of aggression of surgical decision making from the parents specifically.
Not that I've seen overtly. I think that would be, in our culture and the society, that would be unacceptable, or it would be outrageous. Subconsciously, you never know.
Yeah, right? I mean, more subconsciously, obviously, probably not overtly. Yeah.
Yeah, but you have to accept, these things, and I think as we're becoming more knowledgeable, that's the way you fight bias, is you accept it. You accept that there is such a thing, and once you accept it, then you can work against it. So that's usually the strategy that we use to combat that. I think, obviously in the entire world, we have a lot of work to do, but it doesn't mean we don't have other biases though that we deal with that I think are much more common, unfortunately. But I think in this disease process, we can probably put it to rest, because I think there's been so many studies over and over again showing the incidence seems to be just higher in male than female, for whatever reason. I think it goes beyond bias too. That's the disease process, which we know does happen not infrequently. But very good question, and these are things pretty much every disease process needs to be looked at through a lens of bias, as we discover more and more about that.
Awesome.
All right. Do we want to move on to Jose's presentation of the next paper?
It's good for me. You ready to go next, Jose?
Ready?
All right. I think there should be a button down at the bottom. Just go ahead and screen share, just like Zoom. And then once that's up, we can get the screen all shuffled around. You able to find it there? In the meantime, we'll just say, Raina, thanks for your comment. That's why we're doing this. Keep the conversations fresh. Keep a good perspective on everything. Thanks for joining Journal Club tonight. We appreciate it. Jose, how we looking? You able to find that screen share for your slides, or?
Where is it? I mean,
So it should be right in the middle of your screen. Should be a little computer screen with an arrow, kind of similar to Zoom. Just click on that and it should ask you which window you want to share.
okay. Okay. See.
We'll probably turn this off for a second while he finds his slides. If not, we can jump to the next article if we can't get his slides pulled up here. Admittedly, the next article is going to be a little. We're gonna be shooting from the hip a little bit on the next article, or my article. I've had about 30 minutes to reveal it, so we've done no background research, but I've got. What do you want to do, Nikki? You want to just start the next article while you guys troubleshoot Jose's presentation?
Jose's slides, so I can bring those up while you're presenting, and we can share from my screen as well.
Sounds good. I'll trust you and Michael get IT taken care of, and I'll take up some bandwidth in the meantime. All right. So obviously, glad to be here. This is not. I was not the original person scheduled to be here. I'm just going to go ahead and pull up. I don't have slides or anything because I was prepared very last minute. So what I'm going to do is just pull up the article verbatim. And my thought was I'm going to kind of just go through it and kind of point out the things that came across in my mind and sort of give, rather than like a typically prepared journal club with slides, more or less just kind of think in real time, what's going through my head as I'm reading this article and evaluating it. So the overall like big picture of the article is this comes out of the Toronto group. And what they did is a systematic review and meta-analysis comparing endoscopic sagittal suturectomy versus typical open surgery for sagittal suture craniectomy. And all they want to know, the big question they're asking is endoscopic, minimally invasive surgical techniques equivalent or superior to traditional open surgical techniques for sagittal synostosis? The way they did that is through a pretty standard systematic review, which is what they're documenting in their first figure. Now, for anyone that has not done a systematic review, this is pretty bread and butter, right? You pick a handful of, I assume you guys can all see my cursor here. I mean, are you guys able to see? Do I need to zoom in a little bit? Let me see. I can probably zoom in a little bit better, give you guys a little bit better picture. So this is a typical flow chart you would see for any systematic review. It simply just starts by being, the whole point of it is to be extremely transparent about what your research methods are. What are your searching and evaluation methods for the paper that you're presenting? And what they're doing is they're listing the databases that they searched, how many results they found based on the search terms that they used. And then they simply go through their criteria. They remove duplicates that were returned in the same. So then that reduces from their initial search of 489 articles, they've reduced it down to 316. And then they screen those to exclude another 288 from these 316 articles. So that gets them down to a roughly like preliminary eligibility of about 28 articles, from which they then institute the inclusion and exclusion criteria of the study, which I'll touch on in a second. And once they exclude all their papers, it brings them down to roughly about 10 more papers, which they do like a full text analysis and see if there's any other exclusion criteria that would eliminate a study from inclusion in their final meta-analysis. And ultimately what these authors found in their systematic review was that there's 3 articles that met full inclusion criteria for comparing a cohort of endoscopic versus open surgery treatment of sagittal craniosynostosis. That's the lay of the land here. So everything I already went through was pretty much their search strategy, their inclusion and exclusion criteria. This is sort of the next piece of the puzzle that I think of in my head when I'm thinking how I want to evaluate the methods of a paper, is simply like, how do they pick the subjects, or in this case, the papers, because the papers are their subjects. How did they pick their subjects, and how do they decide that subjects or certain papers were not sufficient to be included? And basically what they want to know, they want to include papers where the diagnosis of sagittal craniosynostosis was made officially by a plastic surgeon or a neurosurgeon, so not like a presumed diagnosis, right? Because there are, obviously I don't have an extensive clinical training in craniosynostosis, so I'm not by any means an expert in this, but my perspective is, to the untrained expert, something can seem misshapen, but then, when evaluated by an expert, is not the underlying cause is not deemed to be from premature closure of a suture, right? So they want to make sure that they're only including papers that are distinctly studying a population where the diagnosis was made by a trained expert. And then they also wanted papers where at least 50% of the patient population had isolated sagittal craniosynostosis. So there's a lot of papers out there where they're looking at craniosynostosis at large, various subtypes of craniosynostosis, and the population of patients evaluated in that paper is a mixed cohort. What they want to know is that they have at least a concentrated cohort of at least 50% where the patient population has isolated sagittal synostosis, meaning no other type of craniosynostosis is confounding the patient population. The cohorts needed to be divided into open versus endoscopic assisted surgery. So they've defined their primary comparison for their meta-analysis as comparing the minimally invasive technique to the open surgery technique, and they are only including papers that are directly comparing those outcomes in their paper. And then they obviously needed follow-up in these patients because they want to be able to report on what the actual outcome was at 12 months. So if a paper did not include follow-up data at least 12 months or so, I believe they excluded it from the paper. So that is an important inclusion criteria. Then you get into all the reasons why they ruled papers out, right? They didn't have a quantitative comparison between open surgery and endoscopic surgery. So there was nothing. Basically, as you've already discussed from the first paper, the primary quantitative analysis of the main outcome is a cranial vault index. So basically, if the papers weren't looking at that, they had to exclude it. Obviously, they excluded anything that was done in animals or non-human subjects. They excluded syndromic craniosynostosis, which is a big contributor to many of the cases of craniosynostosis. So they're looking at non-syndromic, isolated sagittal synostosis, craniosynostosis. And then obviously they want to look at data-driven retrospective or prospective papers. So they took out anything that was an editorial, just an abstract, a review paper, case report, or dissertation to make sure that the type of papers included in their study were exactly aimed at getting at quality papers for their meta-analysis. Now, one of the things I thought was interesting is that they applied this effective public health practice project quality assessment tool to basically take every single paper that came in their result and assign it a rating of strong, moderate, or weak in terms of how that paper accounted for or possibly included selection bias, which we've talked about a lot tonight, accounts for their study design, potential confounders, blinding of the study, their methods for data collection, and the frequency of withdrawals or dropouts from the study, and in order to basically say like, hey, we're using this standardized criteria to assign like a health grade or quality grade to the papers. And so that's the general kind of lay of the land of the methods and what they did. Let's see, what else kind of stuck out to me in terms of interesting methods and what I obviously, okay, so now you start getting into like, what are they actually looking at? And the primary outcome of what they want to know is the new surgical method clinically comparable to the old surgical method? And the way they really want to know that is by the cranial index, or the cranial vault index score, which I believe the primary outcome was about like 0.71, 0.72. So it was like pretty equivalent between the two outcome methods. But then they start looking at all these perioperative, postoperative outcomes that we were wondering why the first paper didn't really get at them too much. Looking at things like EBL, length of stay, overall operative time, whether or not there were transfusions. Now, the thing that I thought was kind of interesting as I was reading through this paper relatively quickly is they point out that really only 3 papers met inclusion criteria for their meta-analysis. Yet when they're going through all these sort of secondary outcomes, you know, there's, you mentioned here, 6 studies report this. Whereas 8 studies report this. I'm like, how are they getting 6 and 8 studies? So this is actually what I realized. This is a mixed meta-analysis and review. So in terms of their primary outcome, which I think is down here, right, they're only ultimately comparing 3 papers for EBL, 2 papers for length of stay, and 2 papers for operative time, and I believe 2 papers for cranial vault index. So basically what they found is even among the 3 included, there was only one criteria that all 3 could be compared to each other. There was only one length of stay, only 2 papers can be compared to each other, and operative time, only 2 papers can be compared to each other. So there's just a little bit of like understanding of like how, in my mind, how I'm framing the data, because they're making a lot of claims about, you know, EBL being lower in endoscopic surgery. Okay, great. Clinically, to me, that makes perfect sense. So I don't question that too much when I read somebody reporting that in a paper, but they're really reporting that based on, you know, 3 studies that were included in the meta-analysis, not, you know, these like 6, 8, and 10 studies that were, I think there was ultimately 10 studies they included in the review portion of their paper. Length of stay was a little bit lower, 2 versus 4 days in endoscopic surgery. Obviously, that's important from a, you know, patient recovery and financial perspective. Operative time was lower in the endoscopic cohort, and transfusion was drastically lower in the endoscopic cohort. So basically, in all the outcome measures that seemingly matter, endoscopic surgery is winning. Now, that only matters if the primary outcome of the effectiveness of the surgery, which is sort of what cranial vault index is a proxy for, which I think really isn't even truly like a real clinical outcome, because if you have, I mean, in my mind, I don't think this is the case, but there's just how I think through these things, right? If you have an equivalent cranial vault index between the 2 cohorts, let's say you follow one cohort, or you follow these cohorts out till they're 15 years old and you find out their, neurocognitive development is like drastically worse in one outcome, then maybe I highly doubt that's the case. But that's, I guess, when I think about it that way, that's when I realize that cranial vault index is really just kind of a proxy measurement for a true clinical equivalence. And I don't think we actually have a measure of what that true clinical equivalence really would be. But I would tend to think neurocognitive functional outcomes, neurodevelopment, these are the real true clinical outcomes we would want to know to truly compare clinical efficacy. And in general, just getting into like some of the complications that they had or the rates of complications, I think they basically couldn't compare. It was the ultimate outcome of the paper. They basically didn't have enough data to truly compare rates of complication. But these, everything's all flipped around. I can't rotate these papers. Maybe I can. Never mind. But in general, the cosmetic outcome, which is your cranial vault index, was basically equivalent. So then they go to the secondary outcomes, and this is kind of summarizing the whole paper. I think I'll just turn that off for a second because it's not doing us much justice sideways. Basically, my takeaway of reading this paper and evaluating it in a shotgun fashion is they had 3 papers that were, 2 of them were a retrospective observational study. One of them was a prospective observational study. Retrospectively, everything seems to point towards minimally invasive surgery as being at least equivalent from a primary outcomes, likely superior from a secondary outcomes perspective. And in that case, why wouldn't you go with the surgery that has better, lower EBL, faster recovery time, faster time to discharge, shorter length of stay? These are all reasons why, if your primary clinical outcomes equivalent, why wouldn't you go with something with these better secondary outcomes? However, I think what the authors do correctly identify is that to truly get to a empirically driven decision, the next step would be a randomized controlled trial, randomizing cohorts to endoscopic surgery versus open surgery. However, with the documented benefits of the secondary outcomes, they do suggest that would likely not be an ethical study to conduct, and we should just kind of assume clinical superiority of minimally invasive surgery. I think some other talking points I may have mentioned, just kind of throwing it all out there. I think there was a slight skew towards male population, but we've kind of discussed that as a group. There was something else in there. Let's scroll back through. I'll take a look, but I mean, that's largely pretty much all I got. So should I bring the team back to comment now? How'd I do, Nikki?
Great.
All
10
right.
out of 10.
I got Nikki's seal of approval.
I did just want to address, there was a question in the chat about where the articles are being gathered from. And since there seem to be so many journals and databases and article sources, kind of where do we get these? I wanted to just let people know that the Congress of Neurological Surgeons does have a publication. Hopefully you can have institutional access to it. Otherwise, it's something you'd unfortunately have to pay for. That has a list of essential papers in neurosurgery that have been extensively assessed and covered by various experts in the field. So that's where some of these articles came from. And otherwise, I kind of tend to just focus a lot on meta-analyses and systematic reviews as a way to look at the overall kind of 30,000-foot view of where the literature is at with things like this. But I'm sure Dr. Meltzer also has advice in that regard.
Well, first I have to give you, that was a great job, especially
Thanks.
just coming on that with a quick 30-minute chance to review it. That's really a really great presentation. So I should start out with, again, in the theme of addressing our biases, that to look at my biases with this paper. It so happens that 2 of the articles that were excluded were my papers. So so I have to accept that. Although probably they may have included it in some, as you mentioned, they may have included it in some of the data, but not all of it. But they did exclude 2 of my papers in their analysis. So But
Do you know the criteria that they excluded it on?
they picked 2 papers of mine that had a lot of atopic synostosis.
Oh, so is it just a heterogeneous population?
One had like 49% sagittal, and they wanted over 50% sagittal.
Got it.
So they excluded one of them for that. But I don't disagree necessarily with the analysis. And this group is a very rigorous, very scientific group, and so they're trying to look at things in the most rigorous way possible to avoid criticisms of the data. So I think that's why they were so strict in their exclusion criteria. But I think that you have to look at this paper in through a lens of a term called equipoise. So have you guys heard of this term equipoise? Do you know what that refers to? So equipoise means things are about equal. That you have different ways of doing things, and it may be that each one has its pluses and minuses, and it may not even be something you can compare, as you kind of alluded to. So I think what people are realizing now is that there may be equipoise between these 2 approaches, and the advantage of this minimal approach is that they use a cranial band to help with the result. And so that's the big advantage over that first paper that gets you the better result. But it has to be in someone who's young. Yeah. So there's bias in the age group, because they talk about 6 months, and really
actually
4 months of age. If you're older than 4 months of age, the endoscopic thing isn't going to work, or you might have to wear a cranial band for like a year or more, which becomes a challenge. And the patients in this study, or the ones they look at, need to have a cranial band. What if you're like me, you're practicing in a rural state, they don't have any companies that make cranial bands, or they not really know how to do it after surgery, which is an off-label use of these cranial bands. So how do you even do the procedure then if you don't have access to the cranial band? Well, there's another way to do it where you put a spring in. So that's what we tend to do here, is we use the spring approach to the endoscopic, which is a way to get the same outcome but not having a cranial band. But I think that's your take-home message from this paper is that there's probably equipoise, and it's a bit like apples and oranges. The older kids could do better with that, what we call an open approach, or the cranial vault reconstruction, and the younger kids could do better with the endoscopic, or at least equal to the endoscopic as far as outcome goes, but maybe not have a transfusion, or less cost and length of stay. But your people aren't born with a sign on them saying, I have this disease. You have to figure it out. And so you go see your pediatrician when you're a newborn, like a week later, a month, 2 months, 4 months, 6 months. What if you don't get diagnosed until you're 4 months of age, and you don't make it to the specialist until you're 6 months of age? Well, now you're already too old to have the endoscopic. And that happens a lot. So a lot of people aren't even candidates for an endoscopic. So I think if you're going to do modern craniofacial surgery, you need to be good at both and understand the indications for both. You can do the cranial vault reconstruction on everybody, but you have to wait. You should wait till they're older. So if you only believe in that one operation, you're probably going to tell people, well, come back when you're older and we'll do it. More like 6 months to a year of age, rather than do it at 2 months or 4 months of age. And I think Nikki might have mentioned this one question about, or no, I think you mentioned actually when you spoke about the outcomes. Like, well, is there some way to measure, and also intellectual outcomes? So what if I told you that there actually has been a study that purports that patients who have the minimal invasive endoscopic don't have as good of a neurodevelopmental outcome as people who have a cranial vault reconstruction? What would you say about that? But there is actually literature.
I think it changes everything. That changes everything.
There's that literature is very, very. There's a lot of critiques to that study, but there's at least one paper I'm aware of that claims that a minimal invasive endoscopic approach could have or at least a minimal invasive. I don't know if that was endoscopic, at least minimal invasive, may not have as favorable a neurodevelopmental outcome. But I think that's a very controversial statement.
Yeah. I mean, you have to show that cranial vault index was basically equivalent, but one still had a poor neurocognitive outcome.
And that's the other point that you made that I was going to bring up is that so neurosurgeons tend to be very objective. You know, we like to have objective measurements, and a cranial index gives you a number. But realistically, it's actually a two-dimensional value purporting to give you a three-dimensional measurement. It may not be accurate. So in the pictures that Nikki showed in her paper, she showed like people whose foreheads were bulging out, like frontal bossing. Well, a cranial index wouldn't address that. There were other pictures that she showed of people who had the backs of their heads were tapering out. They call that bulleting, tapering out of the occipital bone. That's not necessarily going to be addressed specifically in the cranial index. But people are looking at different indices to address those types of morphologic changes as well. So I think we will become more robust in how we can compare things and make statements about our procedures. But right now there's a lot of like, you know, looking at things and kind of saying this looks better, this doesn't, than necessarily having an objective number. And the improvement in cranial index may not really tell you how much better things are looking if it doesn't specifically address things like frontal bossing or occipital bulleting. And so those are critiques of this measurement style. But I think in general, I think the paper is reasonable paper, and it makes the point that probably there is equipoise. If you can get someone younger, they may benefit from the endoscopic if you have access to a cranial band or to the springs, as I mentioned. Then that could be a reasonable procedure for you, and could have outcomes that are equivalent to the more invasive procedure. But if you don't get referred until you're older, then you aren't going to really have an option. So I think that's kind of where this paper, and these people didn't just figure this out for this paper. It's kind of, people talk about that already, but this gives you more evidence.
Yeah.
Because it's, and that's the value of this paper, is that the group is really trying to look at things objectively. They're excluding studies that may not be appropriate, trying to really present an argument that's fairly ironclad. That if you are a candidate for a minimal invasive approach, there are potential advantages to doing the minimal invasive approach, and they lay out those advantages in the discussion section.
All right. Do we want to move on to our last presentation from Jose? I think we've got the slides figured out.
All right. Looking forward to it.
All right.
Are you able to see my slides there?
Ryan, are we able to? I'm not seeing his.
Okay.
Oh,
okay. Are you able to see?
yep, that looks good to me.
Beautiful. Okay, perfect. Beautiful there. I do apologize for the issues we have with the technology here, and due to the fact that it's Valentine's Day, you know, they say love hurts there. So, just my name is Takehome, currently a medical student at the American University of Integrated Science in Barbados. And normally I have my partner here, Ali, but unfortunately, due to the time differences, he's unable to participate here. So, but I appreciate his help there. And today we're presenting the topic on early management of craniosynostosis using endoscopic assisted strip craniotomies and cranio-orthotic molding therapies by Jimenez et al. So, basically the objective of this journal, this study here was basically to assess the safety, effectiveness, and results of early treatment of infants with craniosynostosis using minimally invasive endoscopic strip craniotomies and postoperative helmet molding therapy. Basically, what their approach was to basically find a more better approach to the use of to do these reconstructive fiction of the formation of the cranium there, because in the past they used to have a lot of open surgeries, and the problem with these open surgery was the fact that they had a lot of complications and other problems with it, especially during post operative treatments. So they decided to go ahead and do a more try to attempt to a more minimum invasive approach to it. So how they do it was that they decided to take 103 patients who referred from their craniofacial center and diagnosis of craniosynostosis between from May of 1996 to October 2000. And basically, subdivide each groups by based upon randomized subject based upon the formation of the synthesis. This includes sagittal, coronal, metatypic, and lambdoid. And of course, for sagittal, they had 61 patients with 48 boys, 13 girls, with a mean age of 3.2 months. Chronosynthesis had 20 patients with 12 girls and 8 boys, mean age of 3.2 months. Metatarsus structure had 18 patients, 12 boys, 6 girls, mean age of 4.0 months. Lambdoid synthesis, 4 patients, all boys, mean age of 4.1 months. Okay, sorry there. And so therefore, in terms of the results there, when you compare the results of this, what you'll find out is that the compare in table 2 compared to table 3, you will see the differences in terms of the outcomes of it. For table 2 was basically the end result of it, and what you find out is that they had, compared to table 3, was that they had less blood transfusions overall, and as well as also post-operative intra and post-operative blood transfusion, as well as blood volume linked hospital stay as well, because they're looking at hospital stay was one of the big areas they're looking at. It was very minimal when you compare it to when you look at table 3. Basically, they did kind of like a literature review on using the conventional approach to it, which basically the open ones. And as you can see here, the blood losses were variance, but very high in numbers, in both for surgical and as well as also for transfusions and longer hospital stay. And to show this next here, you see these pictures of these patients. All on letter A was the before, and then in in B was mostly, you see, was babies with post-operative 8 months. And as you can see, that the endoscopic approach has shown that have improved the skull formation there, and even once they're all was done, they were placed on these helmets to maintain shape as for a period about usually about up close to about a couple months or so there, and then afterwards they were follow-ups, and then once they feel there were no shade, they would be removed. There was very little complication in terms of the post-operative there. There was one dural tear. Most of them, but the most predominant majority common complication was the front fusion, but improved usually within days post-operatively. So, in conclusion, the less invasive technique have shown excellent results in terms of low morbidity and no morbidity, and associated with low need for blood transfusion, lower hospital costs, and shorter hospital stay. And of course, that the key thing is that in the author made note of it is that the key thing is must early diagnosis of this. And as you mentioned in the previous article in your discussions, that if it reaches to a certain point, then that cannot be determined because they passed the threshold of what's considered acceptable. So therefore, that's why early diagnosis should be, so the treatment could be done more effectively. The sooner, the better, and so that way it can improve their improve their chances of using the surgery to improve their craniosynostosis. This concludes the presentation there. Thank you for your time there, and wait for your question.
Ryan, I think you might be muted.
Oh, nobody can hear me. Okay. I was saying, Jose. I was wondering why nobody's talking. Jose, any final concluding thoughts or questions for Dr. Meltzer, or if not, that's
Well,
okay.
mostly
Go on.
What I like about what I was saying, what I say was that I really enjoyed this article here of this study here because it shows that a more alternative approach to how we approach to of craniosynostosis, particularly instead of using the more traditional open surgical approaches where we have a much larger incision and probably have greater complications, as mentioned in this study here. And what I like about it is that this endoscopic approach is that it has, as like any type of minimum invasive approaches, it has less hospital as well as also um, even sometimes will stay at all in many cases, as well as also blood loss is minimal compared to the open where it was so large that oftentimes transfusions were needed. But we find a very alternative treatment modality in order to improve the formation of these craniosynostosis with great outcomes as mentioned in this article.
That was a really nice job, Jose. What'd you guys think of those pictures that they showed? You guys, what'd you think? You remember some of the pictures he showed in the paper? What do you think the outcomes?
Yes, it's quite impressive. Consider the fact that that was only done. You consider the before and after were 8 months post-operative was quite impressive. Consider the fact that even though there were some, as I mentioned earlier, there were a couple of complications, but they were very minimal compared to, let's say, if we're doing the traditional open method. I could imagine it could have been a nightmare to say the least. But I was very impressed at how it was so how it improved the outcomes. It was so amazing that oftentimes that it showed more the outcomes. What was the target? The two out targets of this article, as I mentioned, was the outcomes and the without the use of transfusions and hospital stay, which shows it was so minimal that complication was like unheard of, despite maybe a couple, but overall compared to the conventional method, certainly was a tremendous improvement.
How many patients were operated on total?
103. It was 100, about 72 boys and 28 girls, I believe.
And how many pictures were shown?
These were in the article there. Those were the only pictures they have available there in terms of the pre and post operative different outcomes there.
Yeah, how many were there?
There were about 5, I believe, in the pictures I've shown.
4 or 5 out of over 100.
Yeah, those are probably their worst outcomes too, right?
Yeah, so what I'm getting at is I don't know necessarily those. You could say that was a representative sampling of just 4 picked at random. I have a feeling those were probably the 4 or 5 best outcomes out of the 100. I mean, I can't tell you that for sure, but I mean, let's just say this paper. I mean, this paper was like a landmark paper, and it really just like kind of throws down the gauntlet. It's like, you know, this is you know, look what we're doing. This is phenomenal, and that's good. I mean, it generates a lot of discussion, and you gotta take it seriously. You know, someone puts a paper out like that, or these authors. It's a husband and wife team. So he's Dr. Jimenez is a neurosurgeon, and his wife at that time, she's a plastic surgeon and craniofacial surgeon. So it's like a team.
Convenient.
So
Interesting.
they're just throwing down the gauntlet, like, look what we could do. And so you have to be like, wow, you know, but you have to also look at it critically. Look at it critically. I mean, it is just 4 or 5 pictures, and they're probably the best ones by far of any of them. Why put them in? Which is okay. I mean, that's fine. But I think you have to, you know, wonder, you know, did all of them come out like that? And I think we don't know. You know, you have to take the word for it. So as far as like the objective data, cranial index, you know, I think that's adds the objectivity. The matopic with the pointy forehead, the coronal where one eye is like big, like a Popeye kind of look. Now, it's really hard. It's very difficult to to um, to get that to where it needs to be with the endoscopic approach. Many authors now, when they show their series in those patients, they tend to be operating on babies that are very young, like less than a couple months old, or they use the springs, which gives you like active force to push the bone apart, versus the helmet, which is more passive and relies on your brain growing to make a change in the head shape. So I think that this paper is a landmark paper. It definitely throws on the gauntlet. Like, if you compare it, it's very close to when that first paper was written, which, you know, was like, this minimal is terrible, and then, you know, don't even go there. And now this person pushes back and goes, oh yeah, look what I got, you know. So you better not, you know, dismiss this so readily, because, and I don't think it's any coincidence that if you look, where were these two centers? The first paper is in St. Louis, Missouri, and this paper is in Columbia, Missouri. So these guys are kind of down the road. They're in the same state and probably compete against each other. So
Yeah.
I don't know if there's any coincidence there. I think there's something to that the one group is like, oh, poo-pooing it. Other group is like saying, no, this is like the best way. So you have to look at that too, right? There's something going on there. That I don't think it's just a coincidence. These two groups just happen to be down the road from each other and probably are competing against each other. And so this competition, you know, maybe that one paper came out first is like, this endoscopic, don't even go there. Now, well, wait a minute now. Don't be saying that about, because this guy, he did you know, he and his wife did 100. So that's a lot. That's a lot of patients. So they were probably doing, there's probably some overlap. There's probably some overlap in the timing of those papers. Probably while the one group is doing, you know, the other one's doing theirs. So they're probably going out at the same time. You didn't just do 100 patients in a year or two. I think that's over a few years, and then with some follow up afterward. So I think, to me, it was really great to pick these out. I'm not sure this intentionally or not, Nikki, but it really shows you two sides of the coin here at the same amount of time, same time period, and the same geography. You know, they're probably competing against each other. So it's probably a little bit of competition here. Probably, you know, the one paper's so forceful because they probably didn't like what that other group had written, and kind of poo-pooing this way of doing things. So they're thrown down the gauntlet. Well, wait a minute now. Don't you be saying this is not a good physique. Look what we could do. Now you try to top this. And with like no blood transfusion, going home like the next day, it looks like. I mean, that I believe, if that's, you know, that's an objective metric when they say they went home the next day. And no, it is not a way you can't really fudge that very much. So, you know, I think they throw down the gauntlet there, and so they're going to be heard, right? They have a voice and they have a platform, and they're going to be heard, and so they just chuck that out there, and so I think it gives you guys a sense of, how this literature thing works, and there's always a backstory going on here, and so these people are have a little agenda probably, which is important to know about, but doesn't mean that the studies are invalid or they're not making a reasonable point, but perhaps making it so forcefully, it may have something to do with some of this background backstory to these papers. So I really applaud you for picking those papers out, Nikki, and
Thank you.
you did a great job on that one, Jose. So thank you.
Thank you, sir.
You all did a great job with these presentations. I'm very impressed.
I had one other quick question. Have you ever come across any papers that have evaluated it almost from a patient perspective? Because I imagine as a parent, the things that you care about the most are kind of the long-term neurodevelopmental consequences, like we had briefly mentioned, and also the cosmetic outcome. So in terms of kind of like the patient satisfaction with what the outcome was, to your point about them only showing photographs of 4 kids in that one paper, I'm just curious if that's been considered much in the literature as opposed to these more objective clinical metrics.
So I think that we did look at that. I'm trying to pull up the reference right now for you, but did look at that in one group. Sorry, to bear with me.
No problem. You've been very patient with us all evening.
So I can send you a couple references that we have on emotional and psychological impact of craniosynostosis repair, which obviously that would come from family reported metrics.
Mm-hmm.
I have another paper on comparison of open versus minimally invasive from the parent perspective specifically.
Okay.
So and that's just my own experience or my group's experience. I'm sure there's others as well. So I think that's really important to look at it from that standpoint. And that's typically why we see people who would like to have a minimal invasive approach,
Mm-hmm.
because they look at it as being less of an issue to deal with when you don't have your child needing a transfusion or having their head swollen and their eyes swollen shut and being in the intensive care unit versus being in a regular room. So that's another reason why I discussed with some of my colleagues the advantages of doing a minimal invasive approach is that many people seek it out. And when we first started doing these procedures, we would have people fly from all over the country when they heard that we were willing to do a minimal invasive approach, because it seemed to the families that that was the best thing. And it was more obvious to the families than it was to the surgeons initially. And I think more surgeons now have evolved toward appreciating these approaches. But initially, it was more the families that wanted to have these approaches. And so the families kind of drove the practice, which I think is important, that we do need to listen to our patients and to our families. And what we think as physicians may be the right way to go may not necessarily be what the families and patients want to do. And so I think it's very important to look at that. If you're going to provide the best care, you do have to look at it from the standpoint of the patients and the families, not just what we think is best as surgeons or physicians, but what do patients feel is the best way to go. And many times it's minimal invasive. And when there's equipoise in the outcome between the two options, many people will pick the minimal option, just based on that alone.
Absolutely. And coming full circle to the first point you made at the very beginning, I think the language we use to describe some of these procedures, like the expanded versus subtotal, that often gets communicated in one way or another to patients, really impacts their perception of what's happening. And so it's, I think, even more important to really explain to patients what's going to happen and what's known about the outcomes.
Do you think as a family member you can really tell the difference? But you understand the difference between subtotal versus expanded. Oh, I don't want an expanded. I want a subtotal. So, yeah, there's a lot of
unless it's a tumor resection.
Yeah, having had family members try to navigate the system for various things can definitely corroborate that. So the importance of educating our patients.
Go ahead. What's that?
Go ahead.
Oh, I was just saying, I've got a question more aimed at fun than serious. I assume you've refereed a fair number of papers in your career. What's like the worst paper you've ever had, like you've read, not like from like a, oh, there's bad writing or, oh, my personal bias. Like you've generally like read the study design or their methods and you're like, I can't believe anybody thought this was publishable.
It happens sometimes. People often throw things against the wall. They wonder what's going to stick. So they think, okay, let's just send it in. You might get lucky. Maybe you'll get a reviewer who isn't going to look at things pretty carefully. But I think it's much better to take your time before you turn in an abstract for a meeting or write a paper. Really be critical about it, because the reviewers are going to be critical typically. And it's best to get it right at the beginning rather than have to go back once. And that's, again, I don't want to come back to this bias again, but the first time you review a paper, if you didn't really think it was done well or submitted properly, and then it gets resubmitted, you have a little bit of a, you're like, oh, this one again. Yeah, I remember. And so it's hard not to be a little biased, even if they've met all your, if the authors have met all of your responses, but you kind of remember, God, it was so horrible when I first saw this one. And maybe in your subconscious, you're not going to like that paper. So I think it's important to try and do the best you can. Just like, let's just get it in there and see what happens. And then they'll like do the, the thinking is like, oh, the reviewers will do my work for me. They'll tell me what I have to do, and then I'll come back and fix it. And so they'll let me know what I need to do, and then I'll do it, and then I'll get it approved. But I'll get it accepted. But
can't say I've never thought that way.
Do it right the first time.
Yeah, I can't exactly say it's good advice, but I can't say it's never crossed my mind.
Spend the extra time up front. Don't trip at the finish line. Submit it the best you can possibly, best abstract you can put together, the best paper you can do. I'm sick. Let's just get it in there, and then they'll do it for me. Don't do it. Then, unless you want your paper published in a journal that you pay money to have it published, right? Which is kind of like it's a big thing in our field, in the fields now, is, how do you handle literature that's published because you paid to have the paper published? How do you compare that to literature that's not of that kind? And that's big. A lot of people fret about this. The rise of the online journal that is geared towards financial remuneration for publication. That's another topic altogether. So,
maybe we need to take journal publication in the nonprofit sector. We need nonprofit journal publishers.
All right, guys, I'm gonna sign out, but I really appreciate the work that you put in, and I'm very impressed. It was a very, very, very nice discussion and really good papers. I'm very impressed. Thank you for inviting me.
Yeah, thank you so much for your time, and happy Valentine's Day to everybody that tuned in today. Thank you so much,
Have a
Dr.
great
Meltzer.
evening.
Have a good night.
All right. Any final words of anything there, Nikki?
I really just, want to thank Dr. Meltzer and also Jose in particular. We had definitely had some last minute cancellations here, and so we really appreciate the students coming through for us to give those presentations, because as you can see, the faculty appreciate it and have a lot of good input on both publications and just in general about the field. So keep
Yeah,
showing
that
up.
was a fun one. Can't really say I'm a craniofacial enthusiast, but I had fun.
Yeah, me
Maybe we'll have
too.
to do this more. Maybe I'll have to pinch hit more often. It'll force me to get out there and learn new things.
Yep, you gotta expand from the Rad and Nordy show.
Yeah, well, I like how silly we keep it on the Rad and Nordy show. On that note, join us Wednesday, 7 p.m. for Rad and Nordy show. We're talking about funguses that take over your brain on Wednesday. Or I guess tomorrow. Oh, gosh. I got to read up on
that
it.
is tomorrow.
Oh, my goodness. It's right around the corner. I guess, all right, well, I know what kind of research I need to be doing between now and tomorrow night. All right, go ahead. I'm gonna go ahead and sign off. And let you go ahead and shut the stream down after you've made any of your final announcements. Thanks, everyone. Thanks for having me.
Thank you.
Have a good night.
Thank you, Jose. Final announcements. Make sure to register for our Women in Neurosurgery webinar, which is going to be Saturday, February 25th at 10 a.m. Eastern, and you can register on our website. Thanks for joining, everybody.